Hello everyone and welcome to today's Lunch and Learn. I'm Deborah Garlick from Henpicked, and today's session is all about cognitive behavioural therapy, CBT. And I know that we're such fans of CBT at Henpicked. We talk about it in all of our training sessions in the workplace. And I'm delighted that today we've got the UK's leading expert on CBT and menopause, Professor Myra Hunter. And the reason we're so passionate about this is because we've seen the huge difference that CBT can have for menopausal women. I know one of our community members joined Myra on the research and was on BBC talking about the dramatic change it made in her life, how she experienced menopause, how she coped with her symptoms. So it's an absolute honour, Professor Hunter, and thank you very much for joining us today. But I'm going to start you with, because this came up with one of our sessions, what is CBT?
Well, thank you, Deborah, and hello everyone. Nice to not see you, but I can imagine you all there now. What is CBT? Well, it's a brief non-medical treatment that's applicable to quite a wide range of problems, both emotional and physical. It's collaborative. We don't tell people what to do in any way, but we help people to achieve their own individual goals. And we offer practical strategies, mainly in the present, to manage problems and to deal with situations, and also hopefully provide new skills that can be applied in many different areas of life. I think one thing that's different about CBT compared with other treatments sometimes is that it's very well researched. We research the development of it for different problems, and we also research how effective it is. But let's get back to basics. What does cognitive and behavior actually mean? So cognitive means it's really our mental processes, what we think, what we feel, what we think, what goes through our minds. So it includes our thoughts day to day, and all the time really we tend to have a narrative going on in our minds. It looks at our beliefs, and I'll give examples relating to menopause. So it might affect our beliefs. We might believe that hot flushes are always really embarrassing. We might believe that everyone notices whenever I have a hot flush. Cognitions also include attitudes and expectations. So we might expect that the menopause is going to be a terrible thing, or we might think, oh, well, I'll do my best and I should be okay. You might have a different sort of attitude. And in general, our appraisal, or what goes through our minds in situations, as well as what happens in our bodies, the way we interpret bodily changes, are really important, and particularly important for managing menopausal symptoms. Come back to this in a moment, but if we think then about behaviours, this is really what you do in a situation. If you're, say, in a stressful situation, or you're having a menopausal symptom, what actually do you do? And it might lead you to avoid situations. Lots of the women we work with, might start to avoid meetings, or they might avoid, well, when we were able to use public transport more, avoid public transport or social situations particularly. One behaviour, you might be feeling irritable or having an argument, rushing too much, trying to do too much. It might be relaxing, being calm, or for some, it might lead you to overeat or overwork, drink too much, exercise, as well as doing some pleasant activities, and we always encourage that. So a whole range of different things. And I think once you think about it, you might become more aware of your thoughts in situations and also what you actually do. Just a couple of examples in relation to physical changes. Now, I used to work with people who had chest pain, and chest pain is a very common symptom of stress, but it can also indicate heart disease. For people who've had tests to show they don't have heart disease, in fact, quite often that belief remains. And when someone has that chest pain, if they're believing that it might be a sign of a heart attack, they're obviously going to feel worse and react differently to those who think, oh, well, it's a sign of stress, I must relax. And similarly for headaches and other responses. And it makes sense that we are alerted to them as potential signs of an illness, but in many cases they're not. And I think that applies to hot flushes and night sweats. Just want to do a little exercise, which you often do in our talks about CBT, that shows the relationships between how we think and how we feel, and how varied these can be. So if you bear with me and think about this little scenario. So you're walking down the street one day, and if you imagine yourself doing that in your locality, and you see someone you know, but you haven't seen them for a while, and you're just about to say hello when they walk straight past you without acknowledging you at all. So have a little think about that, and how might you feel? What might you feel? And that's an emotion. That's perhaps how you feel in your body, and what emotion. And we found, we do this in the groups of women with CBT, and we found that people do have a range of reactions. They might feel anxious. Some might feel a bit rejected or despondent. Others might feel angry, or others might feel concerned for the other person. And then if you think about which category you might be in of those, what you might be thinking about about the person who walked past. We tend to find that if you think, oh, I've upset them, you might feel anxious. Or if you think they ignored me, how rude, you might feel quite angry about it. And if you think, oh, maybe they don't like me, I've done something wrong, or that, that they don't want to be my friend anymore, you might feel a bit upset and rejected. Alternatively, you might think, oh, what's the matter? I hope they're all right. And you might feel concerned. Or you might even feel, some people just think, oh, I don't care. They maybe didn't see me. This happened to me, actually. I used to commonly see someone locally who I would meet in the playground when my children were young. And we hadn't seen each other for a while, and she was walking across the road. And this happened several times, and she just walked past, and I couldn't work out what it was. I didn't think I'd offended her or anything like that. And then I thought, was she too busy? Or she preoccupied? Is she okay? And so the final time, I actually walked on the other side of the road and did have a chat with her. And it transpired that she didn't wear her glasses, so she couldn't see very well. So I thought that was quite a nice neutral situation, neutral response. So always take a pause when you have a reaction, a strong thought, a strong appraisal, or you find yourself reacting quite strongly behaviorally. Just take a few minutes to think, what am I thinking? And is that a helpful way to think? So that's the kind of essence of the CBT. And I said it's based on research, and initially CBT was used to help people with anxiety and depression. And now it's become one of the first options recommended to people in the UK for anxiety and depression. But over the last sort of 10, 20 years, it's been applied to help people to cope with physical health problems, particularly problems like chronic pain, lots of physical health problems, and to not necessarily to get rid of them altogether, but to help people to manage them so that they're less intrusive, so that they bother people less. And I started working on this area. It just shows how long it takes to develop these things and get them evaluated properly, way back in the 1980s. And I was working as a clinical psychologist at one of the first menopause clinics at King's College Hospital. And I was referred women who had distress and physical symptoms, but also, emotional distress around the menopause. And there wasn't a lot of research going on there. And I really wanted to do a PhD at the time as well. So I chose this as my topic, and got really interested in as well as the bodily changes that we're all familiar with, the hormone changes, hot flushes, menstrual changes. But I got really interested in the impact of the psychological changes, factors, and social factors, the social context of the menopause. And, I've been working in the area ever since. And I think I was motivated to try and develop alternatives to HRT, because I was aware that not everyone wants to take that, although it's helpful to have a range of options for women as they go through the menopause. And I think, as I was saying before, I think what's striking is how varied the menopause can be. And I think understanding some of these psychological and social factors helps us to understand why it's so varied for women. We're all different, but we have lots of similarities. And I want to give you just some examples. There's too much. There's not enough time to go through all the research we uncovered, but some of the research that helped us to develop the CBT. So if we think about women living in different countries and cultures, we know that there are examples of how people can attribute different symptoms to the menopause and also have quite varied experiences of it. For example, in Western countries, women tend in general to have slightly more negative perceptions of the menopause and aging and report more hot flushes and night sweats compared with women, not all women, but most women living in India, Japan, and China. This is a changing picture, and I've simplified it, but it does give, there are differences. It's not just one thing across the globe. Another area of research is looking at the negative expectations. And we found that women before the menopause, if they have very negative expectations and attitudes in general about menopause and about aging, they tend to have a more distressed experience of menopause. Because if you think, if we expect to age dramatically, for example, or to fall apart or have no control of it, we're more likely to feel anxious when we're going through it. And I think some of these negative, quite sexist and ageist attitudes that have been around for a long time really, impact on our self-esteem. If you believe all the negative stereotyped images of menopausal women and apply them to yourself, you're not going to feel so good. But there are options, and I think Henpicked is an example of lots of new ways to empower women going through it. So lastly, then, we know that stress, there's research showing that stress affects anxiety. Stress, anxiety, and low mood are all associated with more troublesome hot flushes. And that calm breathing can lower levels of arousal and reduce stress. So putting this all together, I'm talking a lot on this one question. The CBT we've developed focuses on helping people to reduce stress, reduce sleep problems, and reduce hot flushes and night sweats, because these symptoms together are often the main motivator for women to seek help. They can be quite overwhelming, and they all interrelate. And I want to say a little bit about stress, midlife stress, as we call it, because menopause can be stressful, but it also happens in a time during which midlife stress is apparent. And this, I'm sure we're all familiar with elements of this: increased work responsibilities, often increasing or conflicting demands, financial pressures, caring roles, often health problems and bereavements. It can be quite tough, and these affect women more than men, but do reduce as women go through the menopause and go into their late 50s. So this is a vicious cycle, and for these reasons we target the CBT on stress, sleep, and hot flushes and night sweats.
Thank you very much, Myra. That's amazing. And as we say about the research, because if you're not used to doing CBT and you've not heard about it before, you can take a lot of convincing that this really does make such a powerful difference. I mentioned Rebecca earlier, who was from the Henpicked community and appeared with you on BBC talking about her experience. She didn't want to take HRT. It was her personal choice, but she was experiencing extreme hot flushes. And I think if I remember rightly, she was talking about, how much she used to shout at passers-by when she was on the daily commute. And it completely changed her mindset, didn't it?
That's right. And I think it's important, if you're going to do it properly, to embrace it properly. Because Rebecca did. She actually used a self-help version of the book and joined with friends on the program, and was supported by a WhatsApp group which helped her through that. And I think they took their time to go through that. So I'll just say a little bit about the evidence, as you mentioned. Thank you for raising that. So we've now done clinical trials. These are randomized controlled trials where half the women get the treatment and half are on a waiting list or have usual care. And we've now got evidence from over 1,000 women going through these treatments in 6 randomized controlled trials that clearly show that the treatment works and helps women to reduce the impact of hot flushes, to improve sleep, quality of life, and helps them to cope with situations during the menopause. And it's effective. Some of the studies were on women going through a natural menopause, and others were for women who've had treatment-induced symptoms or exacerbated symptoms because of breast cancer treatments. And another study looked at women in a work context. And we did some work with colleagues in Amsterdam as well. In general, we started off looking at the CBT in a group format. So these are groups of women, between sort of 6 to 10 women, a total of 8 hours of contact with a clinical psychologist. So it was over 4 weeks with 2 hours a week, or 1.5 hours over 6 weeks. And we found that these were both effective and as effective, and that the self-help book, which contained the same information as the groups, was as effective on reducing hot flushes and night sweats as well. So that gives a different way of receiving the treatment. We measured beliefs and behaviours. We developed questionnaires and attitudes to menopause, and we found that for people that these all significantly changed across the treatments, and it was the change in those variables that predicted good outcome. I don't want to leave men out, because we also did a study with men too, that which is difficult for men who've had some prostate cancer treatments reducing androgen levels, also experience hot flushes, night sweats, and that can be really distressing. So we applied the treatment for them, adapted it for them, and they had benefits too. And we were just about to start another multi-center study for them. And for the breast cancer women, we have just finished also a multi-center study training breast cancer nurses to deliver the treatment. So it doesn't have to be a psychologist. And for the women in the workplace, which is obviously relevant to all Deborah's work and with you all at Henpicked, the self-help book for women in the workplace, and this was a multi-center study in the UK with 8 organizations. The women just received the book, no clinical support at all, and they had benefits. So I think, to summarize, I think, groups, people love groups, most people do, and I think the groups did provide something extra. But if you haven't got access to a group, then the self-help is as good.
Thank you very much, Myra, because you're right, actually. You can do this individually. You can do this as a group. It's great for support groups in organisations to do. And after this call today, we'll share the resources that are available on Women's Health Concern, the patient arm of the British Menopause Society, and also a link to your book, which I found so easy to read. Because the question would be, how do you do it? How do you start with CBT?
Okay, so well, I think you start with information. I mean, what we start with information and discussion, and in the books we sort of try and make it slightly interactive. So we might suggest that you think about something, as I did in the previous example, and apply that to yourself to try and individualize it. Even in a book format, you can do that. So information about myths about menopause and about the understandings of it in a general way. Discussion help people to think through their own views about menopause and about their symptoms. And we provide cognitive and behavioral strategies such as the calm diaphragmatic breathing, which is really helpful. It helps to counter that arousal that we often find when we're stressed or having hot flushes. Help people to identify and avoid triggers if they want to for hot flushes, such as having too much coffee, running, rushing, being stressed, or it's quite individual. Certain foods can bring them on, arguments, lots of different things. So we help people to identify those so they can modify them if they wish to. I don't want to forget positive changes, because often it's more helpful to elicit positive changes to improve well-being, as well as just focus on negatives such as stress and symptoms. So we do quite a lot of work helping people to find things that actually they enjoy, trying to improve their self-esteem, and I think it's all really helpful and important to do that. And problem solving. If you have an ongoing problem, it's best to try and brainstorm that outside the situation. For example, if at work you're feeling overwhelmed, or you want to be a bit more assertive, to try and find ways to be assertive in a helpful way, or other people might want to say no to things, but finding ways to do that. So we would have some problem solving work too. Perhaps if I give you an example, a work example of women in an office. So classic example,
Yeah,
we've probably all been there ourselves. You know, you're in an office or on Zoom, and we were talking earlier about how Zoom can be helpful in some ways, but actually if you're looking at yourself and you're having a hot flush, it might not help too much. So if you think about an example where about 6 or 8 people are in an office, and some people you're going through the menopause and you're having hot flushes, perhaps younger colleagues and perhaps some senior colleagues, and it's quite formal and you're sitting down, and if you feel a hot flush coming on, straight away you might start to feel tense. So and then we would ask the woman, well, what maybe is going through your thoughts if you're feeling that way? Might take quite a bit of time to get hold of that thought. You might have to think, well, what might I be thinking? So the common thing in our research is people are thinking everyone's looking at me, I might not be able to cope, they'll know I'm going through the menopause, and I don't want them to know that. They might think I'm past it, or they might even think I'm funny. It's funny, but overarching feeling is feeling either I'm embarrassed in social situations or anxious. People fear negative reactions from others, and obviously that fear increases arousal, actually makes the hot flush worse and makes you want to leave the situation. And if we think, then we talked before about behaviors, what's our behavioral reaction? And there's quite limited as to what options there are. I've seen people wanting to cover their faces with their hair or their hands, but that actually doesn't help much. It draws attention to the fact that you're doing something different. Others maybe would avoid or perhaps give excuses not to be at the meeting. And these are all the negative things. And I think we keep an eye out for certain sorts of mental processes which you can do too, such as catastrophizing. If you find yourself always thinking the worst, or then it might be catastrophizing, you might need to find a calmer reaction. And the other one is mind reading. We often think we know what people are thinking, whereas in our research, when we've asked people what, if in a scenario like this, what they might think if a woman near them looks red or sweating, they don't think those such negative things that the woman thinks they might be. And we feed that back to the women. So we don't know what other people are thinking, and we shouldn't think the worst. So they're the sort of negative reactions. So what's helpful in that situation instead? So I think breathing is the calm breathing. We help people to just take a few moments, and that calm breathing not only sort of helps to reduce physical arousal, it also gives you a moment to stop, pause, not to automatically react in our thoughts and our feelings, and find a calmer thought, which you've probably tried to find outside the situation. Apply that to yourself. Let the hot flush flow over you, and then return to the meeting. And I think talking about it, getting support from others, this depends on the context you're in. And we're not suggesting that you should always be talking about menopause in all situations, but I think, you know, if you feel it's appropriate, just factually say, oh, I'm having a hot flush. You don't need to apologize for it or anything. And I think I encourage people to think you're educating other people if you can do that in a calm way. And most people do actually react well to what you say. If you just say I'm having a hot flush, most people give you a more positive response than you think they might.
Yeah, I'll have to say, Professor Hunter, I always feel calmer every time I listen to you. I think we could do that as well. Sally, we've talked a lot about the context of CBT, and we will follow up with where the resources can be downloaded or the book can be accessed. What questions do we have?
Yeah, it was just really, you've talked about, it's absolutely fascinating. And I think the ideas of the way we think about menopause is such an important thing for us to be focusing on. But you talked a lot about the group environment or self-help. Someone asked around a one-to-one therapy around CBT and whether there's evidence around that and the benefits of that, and any thoughts you had on that.
Yes, absolutely. So we started off actually in our initial work doing one-to-one. Yes, so that can be fine. And I think you know, if anyone wants to see a psychologist on their own, most psychologists would be able to offer that. And I think you could take the book, or you know, to get support to do that. But one-to-one, absolutely, yeah. I think you know, there's benefit. It depends on the person. Everyone's different. Some people prefer one-to-one, so there's no rules. I think it is just having options available to women.
And also someone's mentioned about accessing CBT through the NHS. And this is maybe not necessarily a question for Professor Hunter, but for us, we know sometimes accessing support through the GP. And I don't know if you've got any experience of that at all, Professor Hunter, around the access of available therapies on the NHS, or some of the challenges that we know sometimes can face in getting that support from GPs around how to manage menopause, and in particular this approach that we know can be so effective.
Okay, so well, Deborah mentioned the Women's Health Concern information for women, and we also wrote, which is on the British Menopause Society website, information for health professionals, which is for GPs, and actually recommends that GPs can recommend a book if they wish to, or support people through this. But we've been working with the IAPT services, which is increasing access to psychological therapies, which is a services which are in the UK. And I know they are very busy at the moment, obviously, with the increase in people seeking help with lockdown and everything. But if you have anxiety and depression, you should certainly be referred there. I think we are working to make it more available in different ways. So I think you'll see on the resource section, there are ways to find therapists or counsellors. And I think if you've got a good relationship with a counsellor and with the book, you can do it together.
That's brilliant, thank you. So that's the core questions that we had. You've as we've gone through, you've answered. So people say, well, how do I get started? And you came onto that straight away. So thank you very much for covering all of that.
Okay, thank
you.
And
I think I would summarise by saying, you know, there's all of this research that says how CBT works. Anybody can do it, whether you choose HRT or not. You can also do CBT. It's actually good brain training, isn't it?
Yeah.
It's a life skill as well as supporting us during menopause. So it's really worthwhile doing. And the resources are there, whether you know it's free, whether you do it individually or whether you can do it as a group. And I think I would sort of also highlight the case study from Rebecca, whether it's physical symptoms or psychological symptoms. I had no idea there were that relationship, that so much relationship between feeling anxious about menopause and that actually exacerbating your hot flushes and your physical symptoms and your overall experience.
Absolutely.
So the book here, this is your new, this is a new book, isn't it, Myra? Or is this the, I don't know how long I've had this one. I think I had another one before this.
That's just this year. We've also got a second edition of our self-help book, which is actually exactly the same as the one we went through the trial. That's with Routledge. So there's the two. There's slightly different formats, but this one includes a bit more about well-being and menopause symptoms in general. But they're both a CBT. Yeah.
Thank you very much. So it's been absolutely a delight. I shall put the books on screen, and we will be following up with everybody. So it was great to get an overview and a context of CBT. During March, we are focusing a lot on menopause and mental health because of what we're hearing from people at our menopause training sessions around how those psychological symptoms, particularly around COVID, menopause, working from home, homeschooling, looking after elderly folk, it's the perfect storm. So that's why we're focusing on mental health. And we have Dr. Shazadi Harper talking to us about brain fog on the 16th. And then we'll put some more of your some more of your CBT advice into practice and encourage as many people as we can to just download it, read it, give it a try, see what you think. But it's been an absolute pleasure, as always. Thank you very much, Sally.
Thank you, and thank you all for listening. Thank you.